Today we're going to be talking about LGBTQIA+ community, specifically around substance use. We're talking about prevention, treatment, and recovery. My name is Laoch. My pronouns are he, him, or they, them. I'm a Virginia licensed professional counselor, certified rehab counselor, certified brain injury specialist trainer, and I really focus on empowerment-based interventions, culturally competent interventions through trauma pieces. I work in the Richmond, Virginia area. I work at Health Brigade, which is a community-based medical and mental health organization. And I also have a private practice in Richmond, Virginia. I don't have any financial disclosures to state. The only non-financial disclosures I really have are, my first slide lists my place of employment and regional or Commonwealth organizations. Additionally, my presentation does talk about racism, transphobia, and homophobia, as well as equal access to care, which some persons may assign to a political party. Our learning objectives for this session really focus on being able to label, identify, and integrate. So we want to label contributing factors to LGBTQIA+ community members' substance use, and that's our tone of prevention. We want to be able to identify challenges and barriers in accessing substance use treatment. That's our treatment, and integrate community-specific treatment and recovery needs, and that's our recovery. When we talk about prevention, part of talking about prevention is having knowledge, culture-based knowledge. And one of the key pieces of that is looking at this concept of pride. There is absolutely, that tone of pride goeth before the fall. And the pride that we're talking about is number 2 in Webster's dictionary, and that's the confidence and self-respect as expressed by members of a group, typically one that has been socially marginalized. And that confidence and self-respect is based on a shared identity, culture, and experience. So what you have in front of you are pride flags. And the one in the middle that kind of has that arrow with the rainbow after it, that's the more recently and more widely spread flag. And you'll see on that flag, there is the white, pink, and blue, and those are the colors of the trans flag. You see that kind of rainbow flag beneath it, and then you see the lines that are brown and black. And those lines were added specifically to honor and hold in front and respect persons who are of color, persons who are black, persons who are brown, persons who have historically been stigmatized within the LGBT community as well. And there's a space there for honoring that and acknowledging the in-group racism that has been occurring. So if you see these flags, these are generally LGBTQIA+ flags. When we talk about knowledge, because knowledge equals prevention, right? When we talk about knowledge, it's important for us to recognize that gender and sexuality are completely different. The human experience is this wild, magnificent, beautiful thing. And to take into consideration that gender and sexuality are 2 different things is really, really key to how we're going to move forward in providing culturally competent care. Now, I think it's safe to say and important to say, language evolves regularly. The language we used 50, 20, 15, 5, 10 years ago is not the same language that we use now. So I wanted to offer a reminder that perhaps in the next couple of weeks, you're going to see this and say, well, we don't use that language anymore. Yeah, because language evolves. And maybe I'm using archaic language and could do with doing better and upping my language game. So please be aware of that as we talk throughout the session. So gender v. sexuality. Who you love is your sexuality. That is your sexual orientation, but it's not your gender. Our brain dictates our concept of our own personal identity, right? Our brain dictates and helps us polish our beliefs and values. And in so doing, it dictates our concept of gender. And so our gender and concept of gender is in our brain. Gender expression is how we present ourselves. It's relevant to acknowledge that we may present ourselves in a way that, I love wearing black t-shirts and blue jeans, and that presents an assumed identity of who I am, right? Genitals are used to label or assign sex at birth. Assign, right? Not born as, assign sex at birth. A set of genitals does not dictate a person's gender or who they may love. And that blue square we've got around this delightful little stick figure are the perceptions of others, right? That pressure to look, to behave, or that pressure of how we should be moving in this world. And so keeping these things in mind of, thinking about ourselves, thinking about how culture around us has dictated how we move through this world, how we are perceived in this world. How should you behave based on the gender of how you're perceived? And, throughout our treatments, we frequently talk about acting as if. I think the common social way is fake it till you make it, which there's a whole bunch of other things to say about that. However, acting as if, right, that's, I think I am navigating this situation well. I'm challenging my anxiety. I'm challenging my distorted or illogic thinking. So I think I'm doing well, therefore I am doing well. So if we teach that in session around navigating anxiety, or we teach that in session around navigating sobriety or recovery, why then, if our brain dictates our concept of gender, why then does that come up as not making sense or screwy, right? So just really important to keep that in mind as we talk, that gender and sexuality are different things. While we're talking, we are going to be using these words that it's important for you to recognize. LGBTQIA+, lesbian, gay, bisexual, transgender, queer, intersex, asexual, and the plus symbol is for those who are not named. So remember, we just talked about how language is ever evolving. That plus is attempting to keep the door open. Right now, this is the most accepted long form. There's also LGBTQ, which is very accepted, lesbian, gay, bisexual, transgender, and queer. Lesbian, women who are attracted to women, gay, a person who's attracted to the same gender, more commonly refers to men who are attracted to men. MSM is a very important acronym to know. Historically, that has been medical dialogue. We use that, men who have sex with men. People who say, I am MSM, may not align with I am gay. And it's not my job or your job to put that person into a category and say, well, you're gay. That's not how that goes, right? So I know there is also WSW, women who have sex with women, who will say, I'm not a lesbian, I'm not gay. And it is, again, not my job or your job to put a person into a category. Bisexual, someone who's attracted to two or more genders. Pansexual is gender is of no concern. I'm attracted to the person. Transgender, also referred to as trans, that's people who do not identify with the gender assigned at birth. The assigned gender is incongruent to identity. Q, queer, not heterosexual. I think we often see this word used by people who might be younger, in their 20s or younger. I have worked with people who, said, I am a homosexual, which a person who uses the word gay may cringe at, right? Because that's a pretty lab coat word. I've worked with people who say, I am not a homosexual, I am gay, and don't you dare call me the Q word. Like, okay, because the Q word is a bad word, right? When I was a kid, that was a bad word. Well, now it's not a bad word, because why? Language evolves. Intersex, someone born with reproductive or physical characteristics that do not fit into the box as a female or male. I don't know how many people are aware of the tool, the medical tool that is used if somebody is born ambiguous. It's called a phallometer. And I want you to be aware of this because we just said, right, bits and pieces are being used to assign gender. So taking a step back and understanding that it's essentially a ruler, a phallometer, that is used to identify people's gender by measuring a part of their body. Asexual, it's somebody who does not experience sexual attraction to others. And plus, inclusive to others on the spectrum not named. I think it's beautiful that language evolves. I think it's beautiful that we continue to be welcoming and loving and embracing each other. Furthering on that language, so you're aware, AFAB, assigned female at birth, AMAB, assigned male at birth. People still kind of getting stuck in that confused piece. MTF, male to female, that's a transgender woman. FTM, female to male, that's a transgender man. Non-binary, or NB, person who does not adhere to strict binary rules or identifiers of gender. The binary, female, male, non-binary, right? Transsexual, there's nothing there because we're going to talk about this word. This word can be similar to the word queer. It can be challenging to understand or get why this is okay or not okay. Gender non-conforming, not conforming to gender rules, gender variant, gender expressive, just allowing yourself to like relax and live life. Dress comfortably, wear makeup if you want to, have your hair how you want to, wear nail polish if you want to, wear a tie if you want to, right? That's just gender non-conforming. And you see on the screen the umbrella, transgender is an umbrella term. And non-binary can fit in the transgender spectrum. Transsexual can fit in the transgender spectrum. So can genderqueer, so can agender, asexual, agender, without gender. So when we start talking about, well, you know, how do we zoom out? How do we address people? How do we know these other languages? Excuse me. Latinx. It's just the removal of A and O. See the X? MX, instead of Ms., Mrs., Mr., it's mix. So a person who's non-binary would be mix. I would be mix Laoch. Two-spirit, that's indigenous tribal identity for persons who are possibly a traditional third gender or gender variant. This is within indigenous culture. This is not for a white person to say, oh, I'm two-spirit, right? This is within indigenous culture. Cisgender, people who identify with assigned gender at birth, the assigned gender is congruent. Going back, just real quick, transsexual, that may be a term that's focused on medical intervention. So some people find the word transsexual offensive. Some people find the word transsexual really validating. And it's important to ask the person with whom you're working for their language. And, you know, okay, and how do you refer to yourself? Oftentimes when I meet people, I will say, my name's Ari. My pronouns are he, him. If you could tell me your name, your pronouns, what brings you in today? Right? I set the tone for the session. Again, knowledge and prevention. Also, knowledge and treatment. Awareness is what helps us provide really quality treatment. And having awareness of language, rather than othering a person, marginalizing, piling on more stigma, we're letting them know that they're walking into a safer environment to attempt recovery. So the word transsexual can also be validating, right? It's a nuanced language. We're providers. Things are nuanced. A reminder that not all people who are trans identify as queer, gay, lesbian, and or LGBTQIA+ or LGBTQ+. Not all persons who are gay are going to say, yeah, you know, I'm not part of the LGBT or LGBTQ community. It's, again, not my job and not your job to put somebody into a category or into a culture where they don't feel like they align or belong. And the APA a couple of years ago put this reminder out, and this is going back to that first learning slide, is that gender identity and sexual orientation are theoretically and clinically distinct. So it's our job to be really mindful when we're providing services. Again, another language piece, you don't need to add ED to the word, right? So a person isn't gayed or transgendered. Absolutely, 2010 and before, we said transgendered. Language evolved. I'm going to continue to reference that because we are going to make mistakes. I'm going to make a mistake. You're going to make a mistake. This is how we learn, right? Language changes, language evolves. So people are not transgendered. A person may be transgender. A person does not actively undergo getting transgendered. a person may undergo transition. We don't say a transgender or a gay. There's a gay. Hopefully, me using it in a sentence helps to convey why we would not put the word a or put an S on it, right? Oh yeah, there's a bunch of transgenders over there, right? Like, not very person's first language, and also that's not really how we talk, right? So-and-so is a gay, or so-and-so is a transgender. Lesbian is one of the few words that it's, a descriptor and a noun. So yes, S's and a go in front of it. We no longer use the word sex change or sex reassignment. We also don't say a person is transgendering. There's way more than one surgery, so a sex change implies that it's one surgery. Additionally, it's gender confirming, right? It's important to know that surgery may assist with positive feelings towards self. However, some people don't have body dysphoria or gender dysphoria, right? And there's many types of surgery. It's definitely great to be able to say, I work with LGBTQ community members. May not be in the best list of, yeah, I work with clients who are gay, right? Yeah, that client's gay. We don't want to out somebody. So outing somebody is telling somebody's HIPAA information to another person who may not need that for treatment. And when we're doing our biopsychosocial, we may not say, so how does gaying affect your life? How does lesbianing, which is a hard word to say anyway, affect your life? How's your relationship with family of origin? How are your social supports? And, how many close persons do you have in your life? Are you partnered? Right? So that also leaves the door open. Not just for not having to disclose your partner's gender, if I'm not providing that safer environment, and maybe you don't feel comfortable saying that. I'm also leaving the door open for a person who may have more than one partner in their life, right? So it's really just paying attention to those key differences. And people who are members of LGBTQIA community know when it is an unwelcomed environment. I would guarantee that the majority of people who are watching this video right now have been in a space where somebody did not overtly have to say you are not welcome here. However, you knew when you walked into that place, just by the way people looked at you, by the way their body shifted, whatever, that you were not welcome in that space. Language is part of treatment, and using language to let somebody know that they are welcomed into the space of recovery is how we help people, how we angle towards prevention. It's how we navigate to let a person know that that delayed gratification is possible, right? So language, safety, acceptance, not tolerance, acceptance, empathy, compassion. Our language is what helps us contribute to prevention and treatment. So as we move into awareness, now we're going to start talking about treatment. Again, talking about orientation and identity. I really want to hit this home and support this awareness and knowledge. Sexual orientation and gender identity are not preferences or part of a lifestyle. And I was thinking about this the other day when I was in the car. When we fill out medical paperwork or when we talk to a doc, they'll say, do you have a sedentary lifestyle? And it just really made me think of on the medical forms, I do not recall ever seeing sedentary lifestyle, active lifestyle, gay, transgender. It doesn't fit. Also, lifestyle, right? When I say, oh, are you part of that lifestyle? I've already got an idea of who you are and what you do. Lifestyle lets a person know that you're not there to listen to them and you're not there to meet them. And as a provider, if you're not there to meet them and I'm your client, I'm not staying. I'm also not going to believe half the stuff you tell me, right? So lifestyle, take that word, let that word go. Be aware that sexual orientation and gender identity are part of characteristics. Again, not preference, not lifestyle, or a choice. We know that there's no scientifically validated or ethically acceptable way to change sexual orientation or gender identity. So two things. One, this concept of conversion therapy, and I'm intentionally doing that, it's not ethically valid and it's not scientific. Also, all of the folks who may say like, oh, the gay agenda or the recruiting, there's no scientifically valid or ethically acceptable way to change sexual orientation or gender identity. Meaning, when a client comes in and says, I was abused and I think this made me gay, that's simply not true. It's not true. We know that LGBTQIA plus children do experience higher incidence of assault or abuse. And when that child is rejected, stigmatized, picked on by the other kids, doesn't play with the other kids, the adults don't care for this child, they are left on their own. And without that ability to understand delayed gratification, without that protection, without that understanding that like, oh, this is not okay, right? So abuse does not create LGBTQIA persons. And I really want that to be very clear, because I do work with a number of clients who come in who have said, I was abused and I think it made me this way. And outside of, processing the trauma piece is also processing the piece of, it did not make you this way. That it doesn't work that way. That's not how that goes. Dipping into knowledge, terminology is primary, right? When we're working with historically stigmatized and marginalized community members. Told you, I'm going to say it again. This is not preferred or a lifestyle. We want to move into this space beyond cultural competency and move into cultural humility. And that's when we're doing this lifelong education, which you're doing right now, and I appreciate your lifelong learning. And that's also taking a second to step back, more than a second. I don't want to minimize that. It's taking some moments and being really intentional in your thinking to step back and take a look at how a lack of societal power and privilege might shape a person's individual experiences. I encourage you to consider doing an examination of your own privilege and oppression. What have you experienced? And how has that shaped you to who you are now? How has that shaped your beliefs and values? And to sit and take a look at those things. And to consider that when you walk into a room with a client, or when you click on your link and the client shows up or you show up, to consider what has been their oppression and privilege and what has been your oppression and privilege. Because that's what's going to open the door to communication a little bit more. And I think it helps us to understand when we're talking about prevention, I just need to feel good. And this substance makes me feel warm. This substance makes me feel good. This makes my day go by faster. Yeah, because your days are really long and it's been really hard. Having that awareness, having that compassion is what allows us to provide knowledgeable and competent treatment. Accurate history is important when working with marginalized and stigmatized community members, dealing with societal and family rejection and abuse, as well as limited access to care and historical psych and medical prejudice. It was considered a mental disorder in the DSM, right? Until I think it was the fourth one came out, gayness was, and the fifth one was finally addressed some concerns or pieces around transgender. The World Health Organization has changed transgender into a different category at this time. However, DSM, we still have it in the category of, mental health pieces. And people who are trans still have to get letters from medical and mental health providers as to whether or not they can get hormones, which we know improves the overall outcome for people who wish to have them, and letters for surgeries, which again, we know improves the overall well-being and outcome for persons who want surgeries. So let's talk about how we as providers are contributing to marginalization and stigma. When we assume that somebody is cisgender or heterosexual, that client is likely not going to trust us as much if they have to come out to us. And it can contribute to inaccurate reporting of, well, if I have to tell them that I'm gay, and now I have to tell them that I'm smoking weed, or if I tell them that I'm gay, and now I have to tell them that I'm, I'm using meth on the weekends, like, that's just going to stack the stigma. And that's going to make it even worse. And they're going to think all gay people do this. Or if I tell someone I'm using meth and they know that, like, this might move in the gay or queer community, now they're going to think I'm gay. Like, when you make those assumptions, it's putting a person to a category, and we miss out on that really authentic and earnest interaction that we can have with clients. Lack of information or discomfort, as well as bias, can lead to a lack of trust and a patient's hesitancy in disclosing. Challenge your bias, get a peer consultation group going where you're going to be talking about and doing case conceptualization and case review, and really challenge each other when there is homophobia arising, when there's transphobia arising, when there's racism arising. That's that space for us to have that opportunity with our colleagues and peers to say, why are so many women who are Black being diagnosed with bipolar? What's happening there? Why are so many trans men experimenting or living in a world of coke and alcohol? Why is this happening? And what is the relationship there? This is important for us to have those dialogues. And this is important for us to also explore with each other. You will see a collection of coke, a relationship of cocaine with transmasculine or trans men, lesbian women, and heterosexual cisgender men. And it's interesting to get that relationship and take a look at what's going on there with cocaine and how is that related to lesbian, transmasculine, or cisgender men. What's the relationship there and what's happening? We know that marginalization and stigma, discrimination, marginalization, and victimization create elevated levels of stress. We can call that minority stress. And that can make it difficult to regulate emotions and achieve positive interpersonal relationships. So what do some of these drugs do? Ooh, that is called euphoria. That is called euphoria, right? And if I am not safe at my family of origin, I am not safe at my job. I can't be out at my job. Virginia, which is the state where I'm at, just this year, the legislative, they just passed that you cannot fire somebody based on the assumption, suspicion, or belief that a person is a member of the LGBTQ community. Prior to that, a person could be terminated, fired, or evicted based on the suspicion of being a member of the community, LGBTQIA plus community. So if I'm not secure in my housing, or if I'm not secure in my job, I'm not secure in my family of origin, gosh, this one substance makes me feel real good. And now I'm going to take that away by entering into treatment. There's that opportunity for us to start navigating and validating so that a person can feel better and do better and navigate and move into recovery. So what's contributing to use? So we dipped into treatment. We're going to just take a real quick skip back into prevention. LGBTQIA identified youth in particular is a population known to experience higher prevalence of physical, sexual, and psychological abuse. We talked about that, right? The child who's left without affection, and the child who's further harmed by being in their own home. Various stressors due to being in a minority group, such as shame and ostracism when disclosing sexuality. And y'all know, anybody who's facilitated a group has heard that language in group. And it's our job to set the tone in the group and to challenge that language when someone starts throwing out the F word or starts throwing out the T word. It's our job as providers to set the tone of what's acceptable and what's not acceptable. Social pressures and discrimination may limit the opportunities for LGBT individuals to socialize with one another. And as a result, where do we go to socialize with each other? It's not church. It's not school. Oh, it's the bar. I can go to the bar because that's where we have intergenerational connection. And we can hear the stories from our elders, the tales from our elders, the explorations. I will tell you that COVID has had a significant effect on isolation for all of us, and specifically for LGBTQIA plus community members who maybe had to go back in the closet because they had to return to housing with family of origin where they can't be out because it's not safe. They could be kicked out of their house. And if our social activities are concentrated around bars and clubs, I mean, we're going to rock out with our socks out, right? I don't want to be the only person who's not drinking. Additionally, what does that mean when I have to start attending group, NA, AA groups, harm reduction groups, smart recovery groups? What does that mean if I'm not having that connection or that match, right? I do know that AA.org and NA.org, you can look it up and find groups that are specifically for LGBTQIA plus community members, specifically for gay men, specifically for lesbian women, specifically for people who are members of the trans community. You can look that up and find those groups that are really important and really helpful for so many people. So what's contributing to use? Ta-da! Lack of insurance coverage. I'm going to get my medicine. I wear leather coats, even though I'm trying to get away from animal products. I wear leather coats, and I am going to get my medicine from a leather coat or a white coat. That's it. So if I can't go to the doctor and get this medicine, or my insurance coverage is so poor or wretched that I can't get this medicine, I can go get it from, my cousin over there, because I know that my cousin's got what I need, right? Lack of competence. There is some navigation of how to interact within the world, and we use that navigation to find safer spaces, right? All of us use that navigation. Within LGBTQ community, there is very clear knowledge that some providers are not going to offer you appropriate services, and they're not going to be there to support you. Structural and systemic discrimination. Yeah. Hospitals, unless you are next of kin, married, joined by blood, you cannot visit this person in the hospital. The damage that has done, I understand it ish, kind of, sort of, not really. And the damage that has done for people who don't have family of origin, don't share blood with anyone, and maybe haven't gotten married. The systemic pieces of walking into a room and everyone saying, ladies and gentlemen, right? All of the people who are non-binary or agender were just completely left out. I love respected guests, honored guests. Hi, folks. That's a really nice way and really inclusive way to include people. Homelessness, lack of legal recognition, legal rights, poverty. Again, systemic discrimination, poverty. People are not getting jobs. Yes, COVID is absolutely having an effect right now, and people just aren't getting jobs. So when you say it's just a cake, this person just doesn't want to make a cake for this couple. Okay, well, that realtor doesn't want to sell a house or lease an apartment, and that employer just doesn't want to hire. So then what happens? It's poverty. People can't have jobs, which means they can't have insurance coverage. It's just a cake. We're not going to make a cake for a Black man and a white man. It's not just a cake. We're also talking about racism. Racism plays a huge, significant role. The systemic racism that is present in our practice is present in Western psychology. There's so much education and learning out there for all different schools of thought, and yet we're focused on Western psychology as the only way to go, right? I know when I took my exam for LPC, it was all based on Western psychology. I did not have to learn anything about Chinese psychology, African psychology, indigenous psychology. I didn't have to learn any of that. It's all Western, European, white based. And so racism plays, whether I want to acknowledge it or you want to acknowledge it, racism plays a role in how we provide our services. And it's our job as lifelong learners to do our ethical work and to challenge the racism, to challenge the homophobia, and to challenge the transphobia, the biphobia that's in there. So treatment. Nonverbal behavior plays a significant role. Again, we talked about a number of y'all who are watching this video, you've walked into a room before and you knew you were not welcome there, right? Our language, that's why I spent so long earlier on our language. Our language plays a huge role in how people feel received. Before our language is our nonverbal behavior. People are looking and listening for evidence of safety. I want to, invite you and encourage you to look at how you interact with people that you perceive as female. Do you shake hands? Are you super touchy? Lots of hugs? Stand really close? How do you interact with people you perceive as male when you shake hands? There's a very specific way, right? We shake hands differently. One is a soft way and one's like a, hi, how do you do, right? Pay attention to those things and be cognizant. That's gendered interaction. And there's a way to really be intentional of how we're interacting. We do that in our treatment. Why wouldn't we not do that when we meet a client? Again, I will say my name is Ari, my pronouns are. That normalizes the practice. I've had a number of clients who are in the community say like, oh, as soon as you said that, I knew I could talk to you about this. I knew that would be okay. Registration forms. What do your registration forms look like? If there is nothing there about name, it's not preferred pronoun. It is not a preferred name. Again, preference, lifestyle. You want to take those out. Government name. Because here's the thing. You have no problem calling Charles Chuck. I do not understand why there could be a problem calling somebody whose government name is John, Sarah. I don't understand what that problem is. So I want to encourage us to really take a look at this and be like, well, if that's their name, everybody calls me Sarah. Okay, it's nice to meet you, Sarah. It's really generally that easy. Can you put up a rainbow sticker? What do your magazines look like? And again, this is a little bit reflective of pre-COVID, right? What's behind you? What do you have behind you on your screen? If you can see, I don't know if you can zoom, almost all these books focus on trans health. That's what primarily most of my work is within LGBTQ community members. So most of these books over my shoulder, you'll see are trans books. So what's behind you, what's around you, that's very important. Require all clients and staffs to create and maintain safe environment for all LGBTQ community members, and post a non-discrimination policy in this house in this business we. It's keeping and moving and evolving with culture and with life. We continue to evolve. That's, I don't know, kind of the point of the work we do, I think, as providers. So let's start moving into recovery and joining treatment with recovery, right? So that's when we start looking at skill. As we said earlier with group, we set the tone for what behavior is tolerated, who's respected, and how the work is done. Really simple, right? Ethics, respect. Challenge your colleagues, challenge clients and group to say, it looks like you're trying to do something on purpose that's hurtful. Don't do that. Right? That's it. I think I said this even before on a different slide. If we're unaware, we might believe we're seeing somebody's whole personality when they're actually on alert and they're hiding pieces of themselves from us. So are we going to get an accurate descriptor? Are we going to do an accurate diagnosis, right, with our criteria? Because we can tell when we look at somebody in the eye and we're talking, when we listen to them on the phone, we can tell and we say, it feels like something's off. What's going on right now, right? It's important. We have to signal respect, open-mindedness, and acceptance by using appropriate gestures and vocabulary. SAMHSA actually had to put this out. This is on a SAMHSA recommendation for treatment. Discourage others, providers and clients, from making disparaging jokes or comments to or about patients. Staff should discourage others from harassing patients. When we do not correct people in group, that person is harassing another person in front of us. When our colleague makes a disparaging comment about another client, they are harassing a client in front of us. Address people correctly behind closed doors. Do not allow other colleagues to address people incorrectly. You've changed, we're supposed to, like literally, right? We dip back into recovery a little bit more full force. Really important, yeah. But how much does sexual orientation and gender have to do with a person's recovery? I don't know, it's often not the primary presenting concern. The substance use or the presenting concern may be the result of interacting with systems, family, friends, school, providers that have failed them based on bias, homophobia, transphobia, racism, right? So let's look at Maslow. We've got Maslow in front of us. Food, water, warmth, and rest. If I've got to engage in survival sex so that I have a place to sleep at night, I am definitely getting high because I do not want to have sex with this person. I am definitely getting drunk because I do not want to have sex with this person. And it's either here or I'm going to sleep out on the street tonight, right? Survival sex. If I need to or if I'm going to engage in sex work in order to make money, it might be helpful for me to numb out in order to perform or to do this work. Safety needs, security and safety. We touch base on that. Belongingness and love needs. Yeah. Prior to COVID, and in some places I know the bars are opening up again, this is where my group is. This is where my support is. This is where my acceptance is in this bar. It's really hard for me to not drink when I'm in a bar, right? So where else? Where else can we find this connection? Where else can we find this acceptance? Where else can we find our group of people where there's, intergenerational connections? Esteem, feeling accomplished. Look, we're talking about substance use. Tolerance is something that across the board, so many of us have experienced hearing people being like, yeah, this one time and then there's a long tail of all the things they were able to do in one night, right? Where do we get that sense of feeling accomplished if we cannot be out in our home group or our recovery group, or we cannot be out with our provider, knowing all these other pieces? We have the option to tailor CBT, cognitive behavioral therapy, and CPT, cognitive processing therapy interventions to work with minority stress framework. And it might be even more effective because then we can promote awareness, normalization, acceptance, emotional regulation, and validate diverse, healthy expressions of sexuality and gender. Because when we have to learn something new, right, that new neural pathway, that's a muscle, we have to flex it, we have to wear down the trail so that that neural pathway can connect smoother and easier to reach the self-actualization. We can tailor these things to provide the services to a client when we're working together. So a nod to our treatment language. I've used this intentionally a couple of times so that we can hear distorted thinking. Absolutely, definitely clinically accurate. However, we're talking about people who their entire lives have been told that they're distorted, maybe told that they are distorted, illogical, or perverted. So we might not want to use the word distorted thinking. Maybe, well, that doesn't, that sounds like really binary thinking. That sounds like really linear thinking. That sounds like thinking that's limiting you to I don't know, what's happening in your life, right? Rather than saying distorted. Resilience. I'm hoping a couple other people are shaking their head as they're looking at this. Clinically, we know resilience is the ability to bounce back. We use this word just like we might use the word distorted. However, people are getting a little tired of hearing how strong they are. Just be aware when we use those words. Sometimes we overdiagnose and pathologize survival behaviors or techniques. Really not a fan of the word promiscuous. And I hope a couple other people kind of shuddered when I said that word. Survival sex does not translate into promiscuity. Sex work does not translate into promiscuity. I would love to see that word go so far away, specifically because that word is primarily used for AFAB, assigned female at birth, AFAB people, really often used for people who are cisgender women. It's a yucky word. So let's watch our language, right? Identity development and role models of love, safety, and intergenerational relationships. So like, that's my gay mom, that's my gay dad, that's my trans mom, that's my trans dad. Those relationships often help us develop our identity, often help us see that role modeling of loving relationships. It is really hard to find a book on queer love that does not involve some horrific obstacle that a person overcame, became resilient, and developed their identity. It's hard to find those role models. I mean, look at the movies. I encourage you to, watch some of the movies. Laverne Cox put together a really nice movie called Disclosure. I have no relationship with that movie or with Ms. Cox. I will say, however, that book or that movie did a really nice job of telling the narrative of the things that are seen, right? So identity development, role models of love, safety, intergenerational relationships, delayed gratification, quality of life. It's really lacking within LGBTQIA plus community. And it's not because of the community, it's because of that systemic discrimination. So let's talk again about treatment recommendations, still in this world of recovery, talking about that CBT intervention and how we can mold that and shape that. Acknowledge and validate the impact of minority stress. Validate. Explore and educate clients about triggers for use, cravings related to minority stress, right? Well, I get really nervous when I have to go to the doctor's office, so it helps me if I smoke a little weed. Recognize and educate self-regulation, emotion recognition, and self-love and acceptance of, wow, you did a really good job of not yelling at that person when you felt scared. How were you able to regulate that, right? Get somebody to be intentional and aware of the work that they're doing. Teach and support communication that is assertive, passive, aggressive, assertive. So teaching assertive language, I do not like that. Address me this way. That's the incorrect name. That's my government name, I don't use that. Support and praise expressions of gender and sexuality that are affirming. That dress looks amazing. Without talking about a person's body, because that can be kind of yucky sometimes, we can say things like, oh, and what was it like to be able to hold hands in public together? How did that feel for you? And then practicing, right? Role playing, we would use that word. However, role playing doesn't mean the same sometimes in different cultures and communities. So we may say practice. Practice assertive substance refusal with cisgender sex partners, because The Body Is Not an Apology is a great book. No relationship with that book either. And the author talks about my body is so, specifically talking about a person, I believe, who has MS. My body is so, difficult to pose or move for sex that, it's challenging. And, so asking a person to wear a condom or not using drugs, and the person didn't talk about drugs, I'm talking about drugs. That makes sex more difficult. So we need to practice. We need to practice declining substances or practice safer sex dialogues, and connect with other licensed providers so that you can be able to have these dialogues, learn as a provider how to have these dialogues and how to teach these dialogues when you're working with a client, more for the provider. educate yourself. Do not use the client's single narrative to educate you on LGBT plus issues. External messages of hate are internal. They get internalized. So we want to keep that in mind while we're treating. We never want to allow, do you see the shake? That's how serious. We never want to allow transphobic or homophobic comments. Identify people correctly, even behind closed doors, and consider the impact of health organizations ignoring and overdiagnosing / medicating when talking to a person. Not everything needs to be medicated. Not everything needs to be diagnosed. Some things just need to be talked about. Consider celebrating and acknowledging the resiliency, without maybe using that word, of LGBTQIA plus community members, and teach skills to challenge illogic or distorted thoughts, which we might not say illogic or distorted, and consider the person's survival as a measure of strength. There's so many resources online, and this is why you don't need to take that single narrative as the way to define an entire culture and population of people all over the world, right? There's options online. There's the YouTubes, the TED Talks, and the books. You can look in the Googles, and you can find things all over the internets. Audre Lorde, Billy Porter, Sandra Morin, Janet Mock, excellent book. Teak Milan, Laoch Vadmemnon, excellent poet, wonderful writer. Jeffrey Marsh. Within Richmond, Virginia, we have RVA, Diversity Richmond. We have Nations, which is a wonderful organization. We have Health Brigade. In West Virginia, I saw that there's Fairness of West Virginia and Dr. Rainbow of Covenant House. You don't have to, nor should you, rely on a single narrative. So look, read books, ask questions, go to more talks like this, watch TED Talks, have sit-down conversations with people where you're going to push your own bias and say, like, why do I think that? Why am I feeling that? Why am I judging that in this way? I really appreciate your time, and I really appreciate you maybe challenging your own thoughts, maybe hearing things that you don't agree with, and that you're like, I wonder why I don't agree with that. I wonder what that's about or where that's coming from. I appreciate you pushing yourself, and I really value the opportunity to talk so that you can be able to really explore these things, right? You can be able to really question these things, and you can be able to really push yourself to provide services and to label the contributing factors, right? To learn how to label the contributing factors of why members of LGBTQIA community may be using a substance, to be able to identify challenges and barriers in accessing substance use treatment, and to be able to begin to integrate community-specific treatment and recovery needs. Awareness, knowledge, and skill. So thank you very much, and I hope you have a great rest of your day.